I am honored to participate in this East online education activity. I am the past chair of the Surgical Critical Care Task Force of the East Guideline section, and the topic I am presenting is grade methodology, the nitty-gritty. I wish to acknowledge the current East Guidelines Committee Chair, Bryce Robinson, and past chairs Elliot Hout and Andrew Kerwin. They have ushered in grade methodology and guided the transition of East Practice Managed Guideline development to the new grade system. Now, I am not a grade methodology expert. After appointment to the Surgical Critical Care Task Force of the East Guideline section, East sponsored me to take the New York Academy of Medicine TEACH course. TEACH is the acronym for Teaching Evidence Assimilation for Collaborative Healthcare. I would recommend everyone with an interest in participating in an East Practice Management Guideline workgroup to read How to Write an East Practice Management Guideline Using Grade. That PDF document is available on the East website on the Practice Management Guidelines page. Also, the Grade Working Group website is a valuable resource at gradeworkinggroup.org. For starters, I would recommend two journal articles. The first is The East Approach to PMG Development Using Grade Methodology, published in the Journal of Trauma and Acute Care Surgery in 2012 by Andrew Kerwin et al. This article is also available on the East website on the PMG page, and it summarizes the East transition to the grade approach for the development of PMGs. The second is Grade Guidelines Introduction, published in the Journal of Clinical Epidemiology in 2011 by Gordon Guyette et al. This article is the first of a series by the Grade Working Group, providing guidance for use of the grade system. Now, you may ask, what is grade? GRADE is the acronym for Grading of Recommendations Assessment, Development, and Evaluation. The grade system is not simply a grading or rating scheme. It is a systems approach to rating quality of evidence and strength of recommendations. The grade approach involves a comprehensive, organized, and structured process for evaluating research evidence and developing guideline recommendations. Although the grade methodology utilizes multiple sequential steps, the general process can be divided into three main components. 1, establishment of process. 2, synthesis of evidence. And 3, development of recommendations. We will review each of these components shortly. For an example, I will be using one of the earliest East PMGs using grade methodology. That article I will refer to is Timing and Type of Surgical Treatment of Clostridium difficile associated disease, a practice management guideline from East, published in the Journal of Trauma and Acute Care Surgery in 2014 by Paula Ferrada, Ferrada et al. The first methodology component is establishment of process. What is the question? The first step is to determine the healthcare problem of interest, and then to identify the clinical question or questions. In our example, the healthcare problem questions were about the timing and type of surgery in patients with severe Clostridium difficile associated disease. The next step is to create a work group panel of content and methodology experts. In our example, the work group consisted mostly of acute care surgeons as the content experts, but it also included one grade methodology expert, Dr. Shahnaz Sultan. The work group should agree on team leadership and group processes and declare conflicts of interest. The clinical questions must then be converted into the PICO format. PICO is the acronym for Population, Intervention, Comparator, and Outcomes. In our example, the population of interest was adult patients with Clostridium difficile associated disease. There were two interventions of interest. The intervention of early surgery was compared to the comparator of late surgery. The intervention of total colectomy was compared to the comparator of other surgery. The work group should then select the outcomes of interest, considering all outcomes that the population may experience. In our example, the outcomes considered were mortality, length of stay, intensive care unit length of stay, cost, ventilator-free days, renal failure, and respiratory failure. The outcomes should then each be rated for importance to decision-making, whether it is critical, important, or not important to decision-making. In our example, only mortality was deemed a critical outcome for decision-making. Therefore, the two PICO questions in the example were: 1, in adult patients with Clostridium difficile associated disease, does early surgery compared to late surgery decrease mortality rate? And question number 2, in adult patients with Clostridium difficile associated disease, does the use of total colectomy compared with other types of surgery decrease mortality rate? The next step is to perform a systematic review of the published literature and summarize the evidence. I will not discuss all of the details of performing a systematic review here, but both qualitative analysis and a meta-analysis may be performed. For each question, evidence profiles and a summary of findings tables are created. One example of a review manager is Grade Pro, Grade's own software for a summary of findings tables, accessible at gradepro.org. The quality of evidence is then rated for each outcome of interest. Grade describes 4 levels of quality of evidence: high, moderate, low, and very low. For example, randomized controlled trials are initially considered high quality evidence, while observational studies are initially considered low quality evidence. When rating the quality of evidence, each study can be downgraded or upgraded for a variety of reasons. Here is a list of reasons to downgrade. Risk of bias, one example being unequal distribution of confounders between groups. Inconsistency, for example, heterogeneity of the population. Indirectness, for example, the evidence in that study does not directly apply to the clinical question of interest. Imprecision, for example, the study has a high likelihood of random errors. And publication bias. For example, a study with a positive result is more likely to be published than a study with a negative result. Here is a list of reasons to upgrade the quality of evidence. Large effect, for example, a strong positive impact of the intervention may create a large effect on that population. Dose response, for example, the magnitude of the positive impact seems consistent with the dose of the intervention, and increasing the dose of the intervention results in an increased or higher impact. Plausible confounding, for example, a risk of bias inherent in the study likely had blunted the magnitude of the results. Then, the overall quality of the evidence across all outcomes should be based on the lowest quality of evidence in the critical outcomes. The next phase of the process is the development of recommendations. Once all of the evidence has been rated and summarized into evidence profiles, the next phase is to develop those recommendations. The work group should review all of the information to make judgments on recommendations. They should consider the balance of consequences of each intervention and its comparator. The work group should consider the benefits and the harms, balancing good and bad. They should consider probable patient values and preferences. If you were the patient, what would you want? Consider the implications of costs and resource availability. And then consider equity, feasibility, and acceptability. Equity, for example, uniformly available interventions to all. Feasibility, for example, that intervention can actually be performed. And acceptability. Most patients should want it. The direction of recommendation refers to for or against the intervention. The grade methodology guideline recommendations are simplified by assigning only two strengths of recommendations, strong or weak. A strong recommendation means that most patients should receive the intervention. A weak or conditional recommendation means that although most patients would benefit from the intervention, there are different choices available that may be appropriate for different patient situations. EAST has adopted the following wording of recommendations. We recommend for a strong recommendation for the intervention. We conditionally recommend for a weak recommendation for the intervention. We conditionally recommend against, and then we recommend against for a strong recommendation against the intervention. In our previous example, there were two recommendations. We strongly recommend that adult patients with Clostridium difficile associated disease undergo early surgery before the development of shock and need for vasopressors. And two, we conditionally recommend total or subtotal colectomy when the diagnosis of Clostridium difficile associated disease is known. Finally, the practice management guideline manuscript should not only recount the PICO questions, the methods, the results, and the recommendations, but the manuscript should also justify and explain the recommendations, the reasons to select the outcomes, the reasons to upgrade or downgrade evidence, and the reasons to select recommendations should all be explained. The process should be transparent and clearly documented. Details of how work group members voted and the degree of agreement or disagreement should be provided. Finally, the guidelines should discuss the clinical implications, how to implement the interventions, and the feasibility in adhering to the recommendations. The next figure describes the East Practice Management Guideline development process, adapted from the GRADE working group. It is borrowed from Figure 1 of How to Write an East PMG Using GRADE by Rachel Calcutt et al., published on the East website in 2015. This is the summary slide that many people that have used the GRADE system have previously seen. This GRADE methodology process figure is divided into an upper section on evidence synthesis and a lower section on recommendation. Starting in the upper left corner, the process begins with formulating the PICO questions, going across towards the right. Next is selecting outcomes, then rating importance of each outcome as critical, important, or not important, then a systematic review of outcomes, then creating evidence profiles and a summary of findings, then rating quality of evidence for each outcome as high, moderate, low, or very low. And then at the very upper right-hand corner, downgrading or upgrading quality of evidence as it is appropriate. Then going down towards recommendations in the bottom half, grading the overall quality of evidence, and then going back towards the left-hand side, developing recommendations, considering balance of consequences, and then finally, in the bottom half towards the right, creating, writing, and publishing the practice management guideline. I thank you for your attention. This summary slide is a figure of the GRADE methodology process. Thank you very much.